So we're going to move on now and talk about colorectal cancer. Sachi Gupta is here as our co-moderator from Lake Worth, Florida. Sachi's presented a whole bunch of cases for us over the years. She's got a couple cooked up here as well. We're going to be talking about colorectal cancer. And before we get started, we did a colorectal cancer program at the GI ASCO meeting recently, John, and we started out by saying the three most important words with colorectal cancer is biomarkers, biomarkers, biomarkers. So can you kind of update us? It seems like it's changing all the time. Where are we today in terms of how you think through biomarker assessment in the localized and metastatic setting?
Yeah, so I agree. It's still true even today, 2 months later, right? So, in the localized setting, it's pretty easy. I think for biomarkers, we're still relying on MSI high as an important one. But I think where the biomarkers are most critical, at least today, are in the metastatic setting. So important to get that testing at the time of diagnosis. Increasingly, we're not only seeing that the biomarker testing is done, but I think we're now in an era where we need to do it quickly, right? So we've moved beyond to just get the testing at some point. It has to be done as soon as that patient is diagnosed with metastatic disease. The most critical biomarker up front is MSI high, because that impacts our first-line treatment selection. But other critical biomarkers that we really need to know quite quickly include KRAS, NRAS, BRAF, HER2, and then there are some other rare biomarkers that we can find as well out of our comprehensive genomic profiling.
And we're going to get into sort of why for all these things, but as you may have heard, we were just talking about MSI high in the gastric session and how critical that is. And Kristen, we're seeing the same thing as people are more and more aggressive about approaching not only metastatic MSI, but as we were talking about in the gastroesophageal session, localized disease. And actually, Sachi, you were telling me about a 43-year-old lady you've got who has Lynch syndrome. Can you kind of tell them what was going on with her? I'm curious, how you think this went through.
Yeah, a young woman already diagnosed with Lynch syndrome. I think she had some sebaceous adenomas from the beginning, which were resected time and again. She presented with transverse colon cancer. It was T3N1B at the time of diagnosis, so stage 3. She clearly needed chemotherapy. She's MSI high. Now, do you really want to give her all that chemotherapy without immunotherapy, or would just single agent immunotherapy would be a good choice? What is the verdict right now?
Yeah, and do we, this old thing, Kristen, about does chemo work as well, or does it work in MSI high? So for practical purposes, what would you be thinking about? Or are there trials, incidentally, a patient like this can go on, Kristen?
Yeah, so we're on the same page because I actually have a case just like that in my presentation. So it's definitely something that we deal with a lot. I think in the stage 3 setting, we don't have data yet for adjuvant IO alone. Of course, we are waiting for the atomic data, which is not quite the question we want answered, so to speak, because it's FOLFOX plus or minus atezo. But really, we want to know, can we just forego the chemotherapy? Right now, I'm not. For the stage 3, I still give FOLFOX.
So yeah, John, I'm just kind of curious how you're thinking things through and, creative approaches to these situations. We were talking Friday night about, when you have a physician as a patient who can understand, even an oncologist who can understand what MSI high is, and maybe they want to be a little creative. But what are you thinking nowadays in terms of adjuvant therapy for MSI high, and where do you think we're going to be in 2 or 3 years?
Well, there's the textbook answer, which is probably the wrong answer, right?
Always.
Right, and the textbook answer would be, in that setting, to give FOLFOX or combination chemotherapy. But it's not just physicians who are reading. Increasingly, patients are accessing this information. We know a few things about MSI high disease. It does tend to be a little bit more chemotherapy resistant in the stage 2 setting. Adjuvant chemotherapy really provides no meaningful benefit, and we're looking at a situation where patients are potentially taking a lifetime of peripheral neuropathy from oxaliplatin, and they may not have needed it So I have had a number of patients actually decline adjuvant chemotherapy because they read the evidence and they're not convinced in MSI high stage 3 that it's the right thing to do for them. And we negotiate out what we're going to do. So we say, okay, this is one setting where you're on the fence on chemotherapy. We have a prognostic assay currently available to us in a tumor-informed circulating tumor DNA assay. It's called molecular residual disease. And I say, okay, if you're going to decline chemotherapy, at least let's order this test. Because if that test comes in positive, we can say with some certainty that that cancer is still there, just not seen. And if it does come in positive, then in my mind, they have metastatic disease that's not radiographically measurable, and you could invoke immunotherapy at that point.
And other people would say, now you got the patient all upset and you don't have any evidence that you're really going to change anything. But I'm kind of curious, Sachi, we're just hearing so much about cell-free DNA, particularly in colon cancer. Mm-hmm. How, if at all, are you using it in your practice? Would you use it in a situation? What did you do with this patient, incidentally?
Yeah, so this woman, was clearly stage 3, and we thought that she needed chemotherapy, so I started her on FOLFOX. Mm-hmm. But in the same time, sometimes there are elderly patients. For example, a 78-year-old who's in the similar boat. What do you do? 5-FU alone is not going to work as well for MSI high disease. So now, do you give them dose-reduced FOLFOX or?
Could I just ask, what do you think about the idea, though, of getting cell-free DNA?
Oh, I'm sorry, yeah. So cell-free DNA, we've been utilizing it for stage 2 colon cancer, although I have to say that the results do not come back within the time frame that you want to give chemotherapy.
What about in this patient? Do you think it would have helped there?
I did not use it in this patient because stage 3 disease, but for stage 2, I have been using.
Well, John's going to get into that, or we'll talk a little bit about it as we go through here. Why don't we get some data out on the table, and then we'll talk a little bit more. Kristen, actually, let's start out with your case, actually, before you even give the talk. You mentioned it's similar. Yeah. Another young person. We were talking again this morning, gastroesophageal. Again, just quickly, anything new there with young patients? Every time we ask people to present cases, they're always younger. Anything new and exciting there, Kristen, in terms of why?
Still trying to figure that out.
That's what they said before. All right. So anyhow, she gets picked up with a colon cancer.
Mm-hmm. Yep. Yeah, so she actually came to see me after surgery. So she had a colonoscopy for this iron deficiency anemia and was found to have a large ascending colon mass, which was adenocarcinoma, was mismatch repair deficient. So that was tested at the time of diagnosis, which was great. And she did have node-positive disease, and pre-op imaging did not show any metastatic disease. So she came to see me at that point and said, what should I do? She was very well versed, as John mentioned. Patients are becoming very savvy in terms of the data. And so we talked about adjuvant FOLFOX. I actually offered adjuvant FOLFOX, but we talked about ctDNA testing, and she was really interested in that, even though we talked about the pros and cons and the caveats and limitations to that testing. And I won't tell you exactly what happened. She did yet. I will update you later, but it kind of ties together some of the themes that I'll be talking about. All right, so we'll start off with circulating tumor DNA, so the updated data that we heard at ASCO GI in January. So our Japanese colleagues have updated the Galaxy data, which is really looking at patients with resected colon cancer and looking at the utilization of MRD assays and have really demonstrated the prognostic effect of that, as John mentioned. So in the updated data presented recently, they looked at the patients who had the outcome cohort, which is about 3,000 patients, all stages, and the majority of them had data within that MRD window of ctDNA, so anywhere between 2 weeks post-op and 10 weeks post-op, or when they started adjuvant chemotherapy. And what you can see here is that the disease-free survival, the curves drastically did splay, and as you might imagine, the patients who were ctDNA post-op did have much better disease-free survival than the patients who were post-op ctDNA positive. That also was seen in the stage 2 and 3 setting, so specifically the patients in whom this may be slightly more actionable. And you can see here that in the 24-month disease-free survival, about 90% of patients who were ctDNA negative had that disease-free survival, whereas it was only 33% in the ctDNA positive. And in the regression model, the other variables that were important, as you might expect, pathologic staging, as well as molecular status. And then what happened to the patients who were ctDNA positive, who then received adjuvant chemotherapy? How did their ctDNA clear? And you can see here the graphs that show the difference in disease-free survival for patients who had that ctDNA clearance. Again, pretty intuitive, but it's good to actually see that concrete data. And then the patients who had at least 50% reduction in their ctDNA did better, though the differences were not quite as dramatic, but this was important information. I'm not showing it here, but also the investigators looked at transient versus sustained clearance of ctDNA and found that of the patients who had transient clearance, which of course you don't know if they're going to be transient or sustained in the moment, but if they had transient clearance, they wound up recurring in terms of ctDNA within 18 months. So that's all observational data from our Japanese colleagues, but looking now at our prospective data, we also heard at ASCO GI the disappointing results of COBRA. So this was a study looking at resected stage 2A colon cancer patients. So these were T3N0 patients for whom the physician felt that no adjuvant chemotherapy was indicated. And so these patients were randomized to either standard of care, which was active surveillance. They were looking at ctDNA, but that was not immediately available, versus assay-directed therapy. So if they had post-op ctDNA detection, they went on to chemotherapy, and if they did not, they did surveillance. So this was the schema for the patients who had ctDNA positivity, and just to point out the time points of when ctDNA was tested, within 60 days after surgery, and then they started on chemotherapy, either FOLFOX or CAPOX. And then their end ctDNA detection assay was performed right before the completion of chemotherapy. And what we saw here, so this was the early, pre-specified interim analysis that looked at the first 16 patients who had ctDNA positivity. So this was in both arms. So patients, again, had ctDNA tested whether they were on the active surveillance arm or the chemotherapy arm. And what they expected was approximately a 10% ctDNA clearance rate in both arms, irrespective of chemotherapy. But interestingly, what we saw was the ctDNA clearance rate was 43% in the surveillance arm versus 11% in the chemotherapy arm. So that was clearly unexpected data. One of the important things that I think this brings out is the importance of the assay. So this was a particular assay that was used that was an earlier version of an MRD assay, and probably just not the adequate assay to be used. So these patient data will be followed, but unfortunately the study has closed to accrual, understandably, and really kind of muddies the water a little bit more in terms of what we do here. There is another prospective study going on in North America. This is the Circulate, it's now called the Circulate North America study, which is in stage 3 patients primarily, as well as some high-risk stage 2 patients. And this is really an escalation-de-escalation trial based on ctDNA, in which patients have upfront post-op ctDNA testing done, and if they're negative, they are randomized to either surveillance with ctDNA testing surveillance versus chemotherapy, standard FOLFOX or CAPOX. If they're positive, they get either FOLFOX or FOLFIRINOX. So we look forward to seeing the data there, because this is an extremely important population. So moving outside of the ctDNA realm, but I will bring it back with my case, moving on to MSI-high, we've seen a huge amount of data in the last few years looking at all stages and how important MSI status is, both prognostically as well as in a predictive fashion. Of course, we saw the dostarlimab data now a couple of years ago at ASCO from Andreas Ursek, looking at locally advanced rectal cancer, which was MSI-high. Patients got 6 months of dostarlimab. And of course, we saw that amazing 100% CCR rate in the first patients treated here, and we look forward to seeing if this is sustained and whether this can be replicated, reproduced in larger multi-center studies. These patients primarily did require 6 months of dostarlimab, or at least that was the first time point that the majority of patients had the clinical complete response. So a lot of questions here. What about doublet therapy? What about different durations of therapy? Is this going to be reproducible? This is a very small patient subset, highly with a very high percentage of Lynch patients, so a lot of still unanswered questions. But the other interesting study that has recently been presented again that same year was by Miriam Chalabi from the Netherlands, looking at niche 2. This was neoadjuvant nivo-ipi in just very short course prior to surgery. These patients were very locally advanced, highly weighted towards the T4 and N2 patients. And of course, we saw an amazing major pathologic response and path CR rate of about 67% in the niche 2 study with this incredible waterfall plot. Should everybody be getting neoadjuvant immunotherapy? I think it brings up that question, which we can talk about. And then there are a lot of other ongoing studies, including mine, looking at, in the same rectal cancer population as dostarlimab, looking at nivo and ipi, and trying to see how that impacts treatment, path CR, and clinical complete response rate. So what we do have a little bit more data and phase 3 data is in the metastatic setting, so Keynote 177, which randomized patients who were treatment naive to either pembro or investigator choice chemotherapy. The PFS there doubled with pembrolizumab, but as you know, the initial curves actually crossed, and that was somewhat worrisome. The other thing that I think was really interesting is the breakdown of response. So while we saw a lot more responses with pembrolizumab, we also saw more progressive disease as best response. There's clearly a subset of patients who are not benefiting, and we don't understand why. So at ASCO GI, we saw the initial data from Checkmate 8HW, which is looking at nivo versus nivo-ipi versus chemotherapy. We didn't get the data on the nivo-ipi versus nivo comparison, which is what we really would like to see, but we did get nivo-ipi versus chemo. And here, again, much like Keynote 177, we saw these wide splaying of the curve here with PFS certainly, median PFS certainly favoring nivo-ipi compared to chemotherapy. Treatment-related adverse events were as we might expect with nivo-ipi and chemotherapy, though I will note that there were 2 treatment-related deaths on the nivo-ipi arm. So this is pretty concerning, and I think we need to know more about that data, which we will be seeing probably later this year. And just finally, KRAS G12C, we saw an update at ASCO GI. This, of course, was a phase 3 study looking at KRAS G12C inhibition with sotorasib and panitumumab. And the median PFS was improved with sotorasib, panitumumab. But what this part of subset analysis looked at was really the patient-reported outcomes. And here we saw that these really favored sotorasib, panitumumab, as opposed to investigator choice chemotherapy, which was primarily regorafenib or TAS-102. And so in terms of pain, nausea, vomiting, other symptoms, as well as functioning overall, not only physical functioning, but social, cognitive, and emotional functioning, all favored sotorasib, panitumumab. Again, this was the chemo-refractory situation. And patients' perception of their overall status, both at week 9 and week 17, largely favored the soto-PMAB arm. So I think that was important, and we await the overall survival data next. With that, I'll conclude, and I'm happy to give you a follow-up on my case or answer questions or whatever you'd like to do.
Tell us about the case.
Okay, so I had talked to her, so stage 3 MSI high. I talked to her about adjuvant FOLFOX. She was agreeable to do that right before I start adjuvant. So we did send ctDNA, but it does take some time. We use a tumor-informed assay, so it takes a bit longer to receive those results. And in that time period, we actually got a new post-op CT scan, which unfortunately showed omental disease. So we biopsied that. It was persistent disease. So I switched gears and put her on pembrolizumab. She's responding really well. The interesting thing is her circulating tumor DNA has been negative and continues to be negative. So it just goes to show that ctDNA does not always pick up all disease.
So a couple of other questions are coming in here. In a second, actually, Sachi has a case she wants to run by you. But John Layton, one of our favorite docs, who's up on Zoom here today, says the FDA label for 5-FU and capecitabine was modified last week. Should DPD testing be offered to all patients being considered for 5-FU and capecitabine moving forward, or just a discussion with the patient?
Yeah, I mean, I think that's something that we're increasingly talking about at our institution. It's not every hospital, not every practice environment can order it quickly, or it's not a very accessible test. As it becomes more accessible, I think it will be easier to do that. I find that DPD deficiency is quite rare. Additionally, the results from the DPD test can sometimes be difficult to interpret. There's heterogeneity, and so it can kind of put you in a bind as a clinician of whether to give upfront dose reductions or not give it at all. So it's something, I think this is not something we've worked out nationally in our guidelines, and I'd like to see some resolution to that from our national guidelines before I broadly adopt it in all cases. But certainly if I see toxicity in a patient, I would absolutely order that DPD test to understand that better.
So getting back to circulating DNA, another one of our favorite docs in the chat room, Swati, who actually came here, wants to know about using that, Kristen, in stage 4 disease. And would you consider giving people holidays if they cleared a ctDNA? Kind of like a tumor marker.
Yeah, that's a really good question. So in my practice, I don't typically use ctDNA for MRD purposes in the stage 4 setting, with maybe the exception of a resected oligometastatic patient. I know different people do different things, though. I don't find that it adds a lot to standard imaging, since you'll be doing that anyway. I think the MRD, real benefit is in that space where you don't know if there's anything, you don't see anything on scans, and you want to know what's happening on a molecular basis.
I do agree, though, it was a good question. That's a little inside joke we have here. We'll explain later. Anyhow, Sachi, tell them about your 70-year-old lady.
Yeah, interesting case, 70-year-old woman who had T1N1 disease, just 2 positive lymph nodes, MSS. We started her on FOLFOX as adjuvant therapy, and she just had a very hard time, I think developed oxaliplatin allergy or reaction to that early on, so we had to stop that. But throughout her course, she had grade 3 transaminitis, so wasn't clear why she was experiencing that, had to send her and get a liver biopsy. She was diagnosed with primary biliary cholangitis. So Ursodiol took care of that, and then, so overall her chemotherapy was given over 9 months. But in the interim, I was getting nervous, and she was too. So we started to get ctDNA, not the tumor-informed assay, and it was positive at 6 months, and then 8 months. Now she's about to finish her treatment. It doesn't give us a titer, and then even at, I believe, 12 months, it was positive. So it remained positive post-treatment, and at some point she said, "Don't do it again, because her scans were negative. What is the point? You're not going to change anything." So our assay is different. Do they, does it matter to do these tests?
And John, just to take a step back too, because everybody's so excited about it with good reason, but we still really don't know whether it's going to make a difference. And let me ask you, do we know what the lag time is? Like how much earlier are we picking it up?
Yeah, so wonderful data presented by MD Anderson looking at the lag time. So when you have a negative CT scan, as in this case, but a positive ctDNA result. Now, their data set comes out of the tumor-informed assay. It took them a median of 5 months to find the source of the metastatic disease. There have been some really interesting data sets that have gotten to this mystery of what to do with a positive result but a negative scan. One is the Pegasus trial, which was presented at ESMO, and the second was the Dynamic 2 trial, which was presented at ASCO GI. What they found is, if you have a positive result and from ctDNA, but the scans are negative, it's about an 80% chance that there is a metastasis in the liver. On the flip side, if you have a negative result, but there's a recurrence, it's about an 80% chance that it's lung and or peritoneal disease. So for me in my clinic, when I see a positive result from ctDNA, but my CT scan is negative, the very first test I'm ordering is an MRI of the liver, because that's a far more sensitive test to look for occult metastatic disease. I would also consider a PET, which may pick up some metastatic lymphadenopathy, but I've found that the liver MRI for me has been the way to really try to detect that, because the ideal scenario is you can find that single site of metastatic disease in the liver, call up your surgeons, resect that lesion, see a negative result, and the patient remains disease-free.
In a weird way, it kind of reminds me of the prostate people talking about PSMA scanning, because the same exact reason, they can pick up a ligum that's earlier and maybe cure the patient. All right, let's sort of move the ship around to the other direction in terms of other strategies, particularly HER2, which I'm really curious to hear what both of you think about, particularly John, who's been so involved with this. So, Sachi, can you tell them about your 60-year-old man?
Yeah, 60-year-old math teacher, he developed de novo metastatic disease, which was MSS, and interestingly, he had just lung metastases all on the same side, in the same lobe, and the colon cancer. So the colon cancer was resected, and patient started FOLFOX, and at some point we dropped oxaliplatin, but he did have terrible neuropathy. His NGS showed KRAS alteration, so bevacizumab was added to the regimen, but not the EGFR inhibitors, and he also had ERBB2 amplification. So he's been.
Do you know the degree of amplification? Did they say that?
I think it was 3% or something. The VAF, right?
Three times maybe. So that's positive. Yeah. I think depends on the assay, I guess.
It depends on.
So in any case, we scanned him after 12 cycles, and he only had some minimal residual disease in the lung, so we got it resected. And then he had a good 1.5 year of treatment-free time, and he's developed another lung metastases now on the opposite side, which we plan to radiate. But my question is, first off, do you see KRAS and ERBB2 mutations at the same time? Mm-hmm. And then if you do, then would the HER2-directed therapy work in this case with the KRAS mutation being there?
And which HER2 therapy?
Yeah, and which HER2 therapy?
John?
So this is a great case, so thank you for presenting it. About 1 in 4 patients with HER2-amplified tumors, 1 in 4 will also have a concomitant RAS alteration, KRAS mutation. And what we know is that it tends to go along with a lower grade HER2 amplification, and it will drive resistance to our targeted anti-HER2 therapies, so our non-chemotherapy type targeted therapies, whether it be trastuzumab, pertuzumab, and likely tucatinib, trastuzumab, and certainly lapatinib, trastuzumab.
So sort of pathway blockers.
Correct. However, it appears that trastuzumab deruxtecan, which is an antibody-drug conjugate, does have activity against HER2-positive disease that's also RAS mutated. Though I'll point out that it does need to be IHC 3+. So this is one case where you do want to send that tumor off for immunohistochemistry to ensure that there's enough expression of HER2 for trastuzumab deruxtecan to be active.
Does it matter what we send, the initial colon specimen or the lung metastases?
My general preference is to always send the metastasis if I can, because that's the disease that's active in that patient. But sometimes it's just not feasible, so next best would go to the primary.
So John is kind of thinking back to conversations we have in breast cancer about HER2 low when people run out of options, and we see great responses. In this situation, if there are any options at this point, I don't think they're going to be too great. I mean, would you look really that hard, or just try the TDXD?
I'm going to show that data in a moment, but it looks like we need to unlearn that story from breast cancer for colon cancer. Colon cancer behavior is very different. It appears that trastuzumab deruxtecan is almost entirely active only in IHC 3+, minimal activity in a low or intermediate expressing colon cancer.
Because, I mean, I'm not disputing the data, but when you think about the mechanisms of ADC and, you think about the fact that that's the whole idea behind HER2 low is you just need something for the thing to hang on to and then it's going to blast it away. Kristen, you kind of see what I'm getting at here?
Yeah, absolutely. And that's a really interesting question. And also just seeing the heterogeneity of tumor types and how, because the other important point is, unlike in other tumor types, HER2 mutations are not actionable in colorectal cancer. So
they are not?
They are not. So it really is
So
an
as opposed to lung, where it does work and they
Correct.
give it first line, you're saying HER2 mutations, it doesn't work? TDXD?
Correct.
Interesting. So right now, let's say this patient was an IHC 3+, though, John. How would that change the way you think it through?
Yeah, so if the patient is IHC 3+ for HER2, HER2 amplified, and with a KRAS mutation still present, I would start with frontline chemotherapy, standard chemotherapy, but I would be thinking about trastuzumab deruxtecan as early as second line in that setting.
So, and again, Sachi, I know you treat a lot of breast cancer, so let's throw out the old question. We've been doing this the whole time. Every time we get out of breast cancer, we got to ask the other people, what are you doing about screening for ILD? So, Kristen, because it seems like nobody is as aggressive as the breast people. I'm not sure why. Maybe because they have longer, better outcomes. But what are you guys doing, Kristen?
Yeah, so we just have to have a high index of suspicion. So we have to train our nurses and anyone who triages the calls when the patients call in or message in about, I have a new cough. And you also have to teach the patients, too, what to look for. Because the earlier that you see, potential changes and start the steroids, hopefully the better the outcomes are for patients.
And usually, again, once you get outside breast cancer, the first thing you guys start talking about is picking up clinical symptoms. Yet, Sachi, what we hear from the breast cancer people is scan, and get them before they have symptoms so you can stop and restart. But no, it's just interesting. I wonder how it's all going to sort of play out in the future, whether it's ever going to come. I mean, I know they're different diseases, but it sort of is the same drug. What's your experience, Sachi, with TDXD? Also in terms of acute side effects, again, we've been bringing this up as well, the GI issues, but also, have you ever used it in colon cancer?
In colon cancer, no, but in breast cancer, multiple times. It's just another chemotherapy, pretty emetic side effects and hair loss. Some people say they don't see as much hair loss. We do scans every 9 weeks to rule out grade 1 disease and stop the drug and treat with steroids for ruling out ILD.
I mean, that's their mantra, but they're the only ones who are like that. Have you had anybody get ILD, Sachi?
Thankfully, no.
Even asymptomatic, nothing?
Oh, actually, I apologize. I take that back. Yeah, grade 1, I did. And there was a patient who developed that. She had no symptoms whatsoever. We put her on 0.5 milligram per kilogram of prednisone, and her scan cleared up and got back on it, but then progressed.
But you restarted
Yes.
it, though. See, that's what they're trying to do. But again, I don't know. Maybe because your disease is more aggressive. I mean, I don't really know. Or maybe, like I said, it's just a difference of how you're thinking it through. All right, John, let's get some of the more data out here before we go further. I want to get to your case first. Again, just by coincidence, we did a program on BRAF, and just by coincidence, we had like 5 pages. Every single one of them was like under 50.
Yes.
So, I mean, again, also in tertiary centers, of course, you get younger people. But here it is again, 38 years old.
We're absolutely enriched for younger patients at the tertiary centers. So this is a case from my clinic. 38-year-old female presented to an outside hospital emergency room with nausea and vomiting. CT scan showed multiple liver and lung metastases, found to have a rectosigmoid primary, locally invasive, quite bulky, and biopsy confirmed metastatic disease. So the patient was symptomatic, did not have the primary resected, so before they had NGS testing, jumped right in to FOLFOXIRI and bevacizumab, and achieved stable disease as best response, which is a bit disappointing for such an aggressive regimen. The patient remained highly symptomatic from the primary and was struggling with the toxic side effects of that oxaliplatin and irinotecan, and then transferred over to my clinic. And so the question comes to me of what we do next. And obviously, I need NGS testing, as I said. Biomarkers are critical. So we finally tracked down the outside tissue NGS, which showed classic P53 and APC mutations, as well as ERBB2 amplification. And in parallel, I had ordered a blood-based NGS panel, which also confirmed those results as well with TP53 APC and a reasonably high level of ERBB2 amplification. The tumor was MSS. So I made the decision at that point to treat with anti-HER2 therapies. So taking a step back, looking at our national guidelines, we have a number of regimens in our national guidelines that we can utilize. This is a plot that shows the therapeutic landscape of our available anti-HER2 therapies. We've got progression-free survival on the y-axis, objective response rate on the x-axis, and clearly you want to be in the top right-hand corner on this plot. And Mountaineer regimens, tucatinib, trastuzumab, I'll show that data in a moment, and then we have data from trastuzumab deruxtecan as well. So starting first with the tucatinib, trastuzumab regimen. Now this is, just for full disclosure, I was the PI of this study. I launched it as an investigator-sponsored trial as an outgrowth of some work I was doing on EGFR resistance in colon cancer. But this was a study that enrolled patients who had progressed on oxaliplatin, irinotecan, 5-FU, and bevacizumab. What's unique about this study is we accepted HER2-positive results from any local test, as long as it was done in tissue, IHC, FISH, NGS. All patients had RAS wild-type disease because we were confident that RAS mutations would drive resistance. And there was no prior anti-HER2 therapies permitted. Now, tucatinib is an oral small molecule TKI that's very selective. So the goal was to make this a tolerable regimen. So we then went back and we presented this data at ESMO last fall, looking at what happens at that resistant time point for patients who progress after potentially responding to tucatinib and trastuzumab. Now, each row here is an individual patient, and it's stacked from the top having the longest progression-free survival down to the bottom row having the lowest progression-free survival. And what you can see is this flurry of colors here. And what that indicates is there's tremendous heterogeneity of resistance, acquired alterations, typically KRAS, NRAS, receptor tyrosine kinases, this multiplicity of acquired alterations. We only saw 2 patients lose HER2 amplification. So most patients, if they started IHC 3+ by HER2, they remained IHC 3+ by HER2, but they developed resistance by some other genomic acquisition. So that argues to me that we need a cytotoxic strategy to target this resistance, and that ideal strategy would, of course, be trastuzumab deruxtecan. And we first learned about trastuzumab deruxtecan as an active therapy out of Destiny CRC01. This enrolled patients who had progressed on at least 2 or second-line or later metastatic colon cancer. Unlike Mountaineer, this required central tissue confirmation of HER2 by IHC and FISH. Their initial experience was dosing at 6.4 mg per kg, which is the FDA-approved dose for gastric cancer, not breast cancer. Breast cancer is 5.4 mg per kg. Now, I'll point out here to your question, how well does trastuzumab deruxtecan work in patients with low or intermediate expressing tumors? That's cohorts A and B. Not a single response, progression-free survival, essentially at first restaging. All the activity was in cohort A, which was IHC 3+ or 2+ FISH positive. The primary endpoint was confirmed objective response rate, and here's the data from DESTINY-CRC01, very impressive data. Response rate at 45%, PFS at 6.9 months. Now, what I found concerning as a clinician is this toxicity signal. We expected the nausea, the anemia, the fatigue. That's the cytotoxic component of this. But what we were concerned about was the level of interstitial lung disease and pneumonitis we saw. Almost 10% of patients had ILD or pneumonitis, which I think is unacceptably high. And unfortunately, 3 of these patients died. So that's a very high grade 5 event rate. And so that inspired DESTINY-CRC02, which took this same group of patients, HER2-positive colon cancer, by central testing. What's unique about this study is they allowed some patients on who had RAS mutations. They also allowed patients on who had progressed on prior anti-HER2 therapies, but randomized them to the breast dose, 5.4 mg per kg, or the gastric dose, 6.4 mg per kg. And we can see here that the response rate was actually numerically higher with the lower dose, 5.4 mg per kg. PFS, actually about the same, maybe slightly higher with the lower dose. And most importantly, that ILD pneumonitis, no deaths related to drug at the lower dose. So I would say that the preferred dose for trastuzumab deruxtecan is the lower dose, which is the FDA-approved dose for breast cancer. And they went back and looked at who's responding. Almost all the responses in IHC 3+. Only 1 patient responded out of 18 with 2+ FISH positive. Look at the response rate for RAS mutations. Actually pretty decent. 29% response rate for patients who had a RAS mutation with HER2 positivity. And it didn't matter whether a patient had progressed on prior anti-HER2 therapy or not. We still see similar response rates. So for me, once again, it's arguing for a sequence. So how do I incorporate this data into my clinic? We've got great therapies now available for HER2-positive colon cancer. I test for HER2 right on day 1, the moment I know they have metastatic disease. They'll get chemotherapy, bevacizumab frontline, and if there's not a RAS mutation, I would go straight into tucatinib trastuzumab, second line, with trastuzumab deruxtecan as my salvage therapy. If there's a RAS mutation, I would go to trastuzumab deruxtecan to answer your question. So let's move on now to treatment refractory disease. Before 2023, we didn't have a lot. We had anti-EGFR therapies as monotherapy, regorafenib, and TAS-102, and quite frankly, we were appreciative that we had options, but we can look at this data and see that the benefit is pretty modest. The Sunlight trial was published last year by Dr. Prager in New England Journal. This looked at the addition of bevacizumab to TAS-102. This took patients who were within label for TAS-102, specifically progressed on FOLFOX, FOLFIRI, bevacizumab, anti-EGFR, and randomized them to TAS-102 bev or TAS-102 alone. The primary endpoint was overall survival. And the intention to treat showed an impressive survival benefit for the addition of bevacizumab to TAS-102, as well as a significant benefit in PFS as well. The problem with this study, for me, is that this was largely conducted outside of the US, and many patients had not received prior bevacizumab. So if you look at the data, the question is, does the benefit hold up in patients who have progressed through multiple lines of bevacizumab? And the answer is still yes. So for us, this is an important study. It is practice changing or practice confirming, depending on how you look at it. And so this was FDA approved in August. The toxicity signal was as expected with the addition of bevacizumab to TAS-102. And then the next addition here was fruquintinib. So this is the FRESCO-2 trial design. This study took patients who were heavily treatment refractory, so had progressed on FOLFOX, FOLFIRI, bevacizumab, anti-EGFR if eligible, and they had to have progressed on either TAS-102 or regorafenib. Took patients and randomized them to fruquintinib, which is an anti-VEGF, anti-VEGF receptor tyrosine kinase inhibitor, or a placebo. Primary endpoints overall survival. And this study was strongly positive in favor of fruquintinib with a nearly 3-month survival benefit. Also a substantial benefit for PFS as well. Safety summary is shown here. The main side effects, adverse events to look out for are hypertension, asthenia, and decreased appetite. So stacking up the third-line options for metastatic colon cancer, we've got regorafenib, we've got TAS-102, bevacizumab, and fruquintinib. I think nationally, TAS-102 and Bev seems to be the most commonly prescribed third-line option, but not every patient will be ideal for that regimen. And there are a number of factors that I use to figure out which one I would give third line versus fourth line, including prior therapies, comorbidities, tolerability, activity, and access. So we can focus on this later, but looking at microsatellite stable, HER2 negative, BRAF wild type, we now have a number of options available in this third and fourth line setting. And as I'm sure Kristen will tell you, there's, as we learned from Codebreak 300, we've got a new target emerging, which is KRAS G12C, with multiple new therapies entering the clinic.
So Sachi was just messaging me that fruquintinib sounds like a regorafenib light, sort of, and better tolerated regorafenib. Boy, what a history with regorafenib. Just kind of curious, Kirsten, John put up a bunch of factors that he thinks through, I guess particularly fruquintinib versus TAS-102 versus maybe TAS-102 plus Bev. What's your usual thought process there?
Yeah, it's interesting because fruquintinib, the label, the FDA-approved label, is actually in the third line and beyond, which is not what FRESCO-2 enrolled the patient eligibility was, but that was based on the combination of FRESCO, which was done in China, and really was a third line study. So that being said, so you have the option. That being said, I think TAS-102, I usually do TAS-102 Bev followed by fruquintinib. And that, one of the things that does sway me is the presence of cytopenias and bone marrow suppression from prior therapies, because TAS-102 does have a higher incidence of that.
All right, so I got to try to squeeze in this case from my friend Dr. Levy. We'll see if we can do it in 30 seconds or less. So John, 60-year-old patient with Lynch syndrome who recurred after completing adjuvant FOLFOX for stage 3 disease, developed liver mets for which the patient received Pembro, complete response. Treatment interrupted due to grade 3 colitis and immune-mediated pancreatitis, requiring hospitalization, high-dose steroids with resolution of symptoms. Patient remains in CR by MR of the liver and ctDNA. So John, if he recurs, Dr. Levy wants to know, would you re-challenge with an IO?
Oh, that's
Hope he doesn't recur.
Yeah, that's a tough one to give me when I only have 30 seconds. So ideally, if he recurs, we would try to resect that recurrence. Okay. Try locally directed treatments would be my preferred option. It would be difficult, but look, I mean, the fact of the matter is we can cure people with immunotherapy, and so that will lead to a very difficult conversation with that patient.
Sachi, you had a question?
Yeah, I mean, not all MSI high patients, metastatic disease, respond to immunotherapy. What do you do for the ones who don't? Is there a role for combination immunotherapy, or when would you use combination over single agent?
Kristen?
Yeah, so I think that's where the Checkmate 8HW is really going to be helpful, because until now we've really only had cross-trial comparisons of doublet versus monotherapy with IO. So the question is whether that 30% of primary or refractory patients to pembrolizumab will decrease with the combination, but yet we don't know.
So one final question. Actually, like 3 different people brought up this question. I'll just pick one person from Dan. Young, fit patient, DMMR, metastatic CRC with bulky disease, chemo plus IO, IO alone, double chemo with bulky, let's say, symptomatic disease. John?
So I think most of us still prefer to follow the Keynote 177 data with single-agent Pembro, but if it's bulky, symptomatic disease and I need to generate a response and quickly, that's where I'm looking at an Ipi-Nivo potential combination in some cases. I mean, I think the data is quite compelling, and there are some scenarios like that where I will consider the doublet.
Awesome. All right, we're going to move on and talk about pancreatic cancer. Thank you so much.